Good afternoon, ladies and gentlemen. My name is Nur Azira and I'll be your MC for today's event. Welcome to the Singapore leg of the JBI Global Solution Room. The JBI Global Solution Room is a week of events on evidence implementation held for and by practicing professionals across the globe from 6 to 12 June 2022. It comprises a series of dynamic interactive sessions to provide pragmatic solutions to challenges in getting evidence into practice in the clinical setting. This webinar is jointly brought to you by JBI Adelaide, the National University Hospital Centre for Evidence-Based Nursing, a JBI Centre of Excellence, and the Institute of Mental Health Centre for Evidence-Based Practices in Mental Health, a JBI affiliated group. This event will be recorded. May I invite Dr. Siti Zubaida to give an introduction to JBI. Dr. Siti is the Assistant Director of Nursing at the National University Hospital, NUH, and also holds the position as Director of the Singapore NUH Centre for Evidence-Based Nursing, a JBI Centre of Excellence. Dr. Siti, please.
Thank you, Azira. A very good afternoon to everyone. Now, before I start, I would like to do a quick poll. On a scale of 1 to 5, to what extent are you familiar with JBI? 1, being do not know at all, and 5, you know JBI very well. Let me start the poll. Okay, we wait for a few more minutes. All right, looks like we have a lot of work cut out for us, right? About 56% of people, of the participants, do not know what JBI is. Okay, this will be a good opportunity for me to share what JBI is all about. Thank you very much, everyone, for the participation. So you can see the results. Okay. Okay, sorry, I'm not able to share the results, but just to let you know, about 57% do not know about JBI. 20% knows a bit. Yeah, not very many knows JBI. So this would be good for us to share what JBI is all about. Right, can you all see my slide? Can you all see my slide?
Yes, Dr. Siti, can see us.
Yeah, thank you very much, everyone, for joining us for yet another session of the JBI Global Solution Room Singapore. Now, this is my agenda. Okay, we'll take a quick peek at JBI collaboration, what JBI collaborations, overview of the JBI framework, and the Global Solution Room. Now, there are 3 major collaborating organizations to promote the use of evidence at a global level. Now, let me give you an overview of these collaborations. Okay, we've got the Cochrane collaboration. Its focus is mainly on medical. The types of systematic review it produces is on effectiveness and diagnostics, and resources from that collaboration is they produce systematic reviews, clinical trials, health technology assessment, and the database of abstracts of reviews and effects. For the Campbell collaboration, it focuses on sociology, psychological, educational, policy, and criminology disciplines. It produces systematic reviews of effectiveness. You have systematic review protocols and reports, plain language summaries, policy briefs, and evidence portal. And JBI collaboration mainly focuses on nursing, some allied health, and medicine. The types of systematic review is comprehensive. It includes systematic reviews of effectiveness, diagnostics, observational, and qualitative. The resources that JBI has are the systematic review protocols and reports, evidence summaries, evidence-based recommended practices, best practice sheets, technical reports, and consumer information. As you can see, the JBI collaboration appears to be closest in meeting our needs for nursing. So, who is JBI? Okay, JBI is a leading global evidence-based healthcare organization cited in the University of Adelaide in Australia. JBI's vision is to provide better evidence to achieve better outcomes and a brighter future. Its mission is not only to promote, but also support the use of evidence at the point of care globally. So international collaboration is critical not only to JBI, but to the broader healthcare, evidence-based healthcare endeavor. So what is evidence-based healthcare? Now, when making a practice change, it is important to consider the evidence around the intervention that you want to introduce. By ignoring the evidence-based recommendations, instead of improving patients' outcomes, you may end up causing harm instead. Thus, evidence-based recommendations is a critical piece when making a practice change. Besides the evidence, healthcare professionals must also take into consideration the context in which the evidence is to be implemented, professional judgment, and patient preferences. So all this encompasses evidence-based healthcare. JBI has designed programs to enable the effective implementation of evidence and evaluation of its impact on clinical practice. Now, the unique approach is encompassed in the JBI model of evidence-based healthcare. At the core of the model is the approach to decision-making, where healthcare professionals need to consider the feasibility, appropriateness, meaningfulness, and effectiveness of the evidences to their practice. The basis of a timely, reliable, updated best practice is when practice is based on evidence. Thus, evidence is an important piece and underpins all the elements within the JBI model. Evidence synthesis is where global evidence is appraised and synthesized in a systematic and scientific approach to make evidence-based recommendations to practice. This work is so important to health professionals like us and forms the first step to evidence utilization. With so much of this knowledge generated by the JBI, this evidence needs to be disseminated in appropriate relevant formats to inform health systems, health professionals, and consumers. Active dissemination is conducted via social media, integration of the evidence into clinical systems, and providing education by JBI and its collaborating centers. All of the work by the JBI and its collaborating centers culminates in the most important piece where it matters most: utilization of the evidence by healthcare professionals into the clinical setting to improve patients' health outcomes. And this is where my colleagues shall be sharing some of the exciting work that they have done on this evidence implementation later on. Finally, all these activities culminate in JBI's priority in providing a framework for the use of best available research evidence to inform clinical decisions to impact health outcomes of people worldwide. Thus, JBI offers a unique range of solutions to its users. Access to evidence is provided through the JBI EBP database, evidence synthesis and evidence implementation publications. Resource to appraise evidence can be done in summary, and review manuals and systematic review training is made available to provide guidance and education. For evidence implementation, JBI PACES facilitates the audit process. Evidence implementation manual and training is made available to guide the users on this aspect. Now, JBIC is the largest global collaboration to integrate evidence-based healthcare within a theory-informed model. Today, JBI has 70 plus collaborating centers across 40 plus countries working in partnership with experts from both academics and hospitals with the sole intention of improving health outcomes of patients and individuals. And NUH and IMH are the two JBI centers in Singapore. Now, this picture is taken at one of the JBI meeting where the directors from the collaborating centers used to meet annually. Now with COVID-19 not so much. Okay, collaborating entities are self-governing and leads evidence-based initiatives in their region, country, state, or specialty, just like us in Singapore, just like our centers in Singapore. And yet we are driven by a united desire to contribute to improvements in the quality and outcomes of healthcare globally. And this is where we contribute at a global level. New knowledge is not automatically translated into behavior and organizational change. And this is why a large gap exists between research and the adoption of evidence into practice. According to Strauss in his book on knowledge translation, it takes about 17 years for evidence to be adopted into practice. By then, this will be outdated practice. So how then can we close this chasm? Think globally and apply locally. Globalization. Now, globalization, tracing its roots from a Japanese term, dochachuka, localization emphasizes the use of global evidence and adapting it to local practice. It is an opportunity to share experiences and co-create partnerships for purpose to achieve better health outcomes by applying global knowledge to local challenges. The Global Solution Room is an opportunity for JBI and JBI collaboration to engage healthcare professionals in a solution-focused and pragmatic way. If you are interested to find out more about JBI, these are some ways to connect with them. And I hope you will have a fruitful webinar in this Global Solution Room. With that, thank you very much for your attention. Back to you, Azura.
Thank you, Dr. Siti. Before we start, I would like to go through some administrative details. I would like to encourage participants to post your questions through Pigeonhole. Participants can access the website either by scanning the QR code or typing in the URL shown on the screen. After entering the passcode on the website, participants can then post your questions on the platform. Participants can also vote for the question they would most like to be answered. The questions will be moderated and answered during the Q&A at the end of the session. We will be starting with a series of presentations by 3 of our invited speakers with a break in between. After the presentations, we will be concluding the event with a Q&A session. We look forward to everyone's active participation and having fruitful discussions today. The first speaker is Dr. Hui Ting Xue, an educator at the Institute of Mental Health, IMH. Dr. Xue has worked extensively with mental health consumers and nurses with experiences spanning over clinical practice, education, and research. May I invite Dr. Xue to share about the key features and impact of gamification on mental health for children and adolescents. Dr. Xue, please.
Thank you, Azir. Thank you for the kind introduction. Let me then share my slides first. Good afternoon, everyone. My name is Hui Ting. I'm a senior nurse educator at the Institute of Mental Health. And today, I'm very pleased to share with you about a little project that I've done looking at key features and impact of gamification on mental health for children and adolescents. So whatever I'm sharing is in my own personal capacity, and I'll be happy to address any queries that you may have in a moment. Now, just some background to why this project is done in the first place. As we know from the title, the focus has been on mental health of children and adolescents. So, and it is a topic that requires a lot of attention. I mean, the World Health Organization has indicated that about 1 to 2 in every 10 children, and that's about 20% of children and adolescents do suffer from mental health conditions. And in addition to that, mental health conditions can also account for a great deal of the global burden of diseases. And in children and adolescents especially, imagine getting a mental health condition, and worse still, a disabling one as young as maybe age 14 years old. And imagine the next stage of their life, all the way extending to adulthood, may be impacted by the disabling mental health conditions. So there could be wide-ranging effects impacting on educational attainment, social relationships, or even physical health, limiting the opportunities for children and adolescents with mental health conditions to lead fulfilling and productive life. And in locally, or sometimes also in United Kingdom, and different parts of the world, suicide, especially in youth and adolescents, can be the third leading cause of death. So there is really a dire need to address mental health conditions in children and adolescents. But before that, we also done a little literature review before zooming into a specific review. So this little literature review actually tells us that gamification is gaining traction. There's been a lot of interest looking at what gamification is about. And gamification, to be utilized in healthcare, is defined as the use of game design to promote positive health. So there has been a proliferation of interest in gamification. I mean, if we think apart from healthcare, we think about education. Now, in education, there has been a lot of talks about serious gaming, learning through games, and so on. So, and even for our own individual entertainment, now, in playing games while waiting for someone or waiting to spend time, gamification can be something that may be of interest. So therefore, my slides is moving on its own. So therefore, gamification is something that has the potential to be used beyond all day for entertainment or pleasure in healthcare setting as well. But then, despite the mental health issues in children and adolescents requiring to be addressed, the evidence on gamification, specifically in the area of mental health, is lacking. Now, there has been benefits of gamification in the area of improving thinking, improving social and emotional state. But then it is said that gamification to address mental health is very much in its infancy. And that's one of the pertinent literature gap that needed to be addressed. And then if we look deeper at it some more, the effectiveness of gamification for mental health in children and adolescents also either remains largely unknown. So there has been some evidence here and there, but then a lot of times study in greater details about its impact and effectiveness is largely unknown. And even if we know about the impacts, such as some studies have shown that it can help depressive symptoms, it can increase perception of pleasure and enjoyment. But then there are contradicting evidence as well to say that despite improving enjoyment, improving pleasure, it could worsen sleep quality and impact physical health as well. And let's also think about what comes to mind if we think about gamification. For me, 3 or 4 things comes to mind. Gamification gives me pleasure, entertainment, relaxation, and most importantly, fun. And for children, adolescents, what do they want? If you ask if you have kids or if you ask any young children, most of the time they will say, oh, they want fun, they want enjoyment. So gamification actually has a lot of potential to be utilized into healthcare, and furthermore, utilized to impact healthcare and specifically maybe mental health in children and adolescents. But then this has not been well studied. So therefore, this project has a very specific aims in a way, firstly, to actually uncover the key features with regards to employing gamification methods and as well as its impact on children and adolescents' mental health. Pardon me, I don't know why my slides keep moving, but specifically, it aims to address the following questions. What are the gamification approaches that impact mental health outcomes, and what is the impact of gamification approaches on mental health outcomes in children and adolescents? For this study, what we have done is to carry out in the form of a scoping review methodology. And what is scoping review? Now, despite earlier we have seen that some of the preliminary evidence suggests that gamification can actually help or aid in depressive symptoms. But then at the same time, when we do a scoping review, we are able to actually uncover more evidence with regards to different mental health conditions, different mental health symptoms, and we can broaden up the search. So hence, we use the methods recommended by Joanna Briggs Institution or JBI to specifically search for literature pertaining to the participants, context, and concept components. So this is a little representation of how the study has been conducted, where this is a literature review, or specifically a scoping literature review study. And we went to scope the literature specific to children and adolescents as the participant groups, and gamification approaches as a concept. And gamification, as we have defined, is the use of game design elements to motivate positive health. So hence, different kinds of, and being scoping review, we actually try to gather findings about effectiveness of gamification approaches for mental health outcomes, including changes in symptoms of mental conditions, behavioral changes, and mental health recovery were included. Being a scoping review also tried to scope literature across multiple settings. So it's not specific to the mental health settings, but what we want, but because we have one of the aim to find out about the impact of gamification on mental health. So therefore, we only restrict our articles to studies that actually have a comparison group. So comparing gamification methods to either usual care or any other kinds of therapies or methods to help mental health in children and adolescents. So studies that did not make any comparison were excluded. So again, using JBI methodology, which has a wonderful three-step approach, we started off looking at only two databases, MedNight as well as CNOW, to find out what could be the potential search terms in order to expand the search. And for example, instead of just initially thinking about gamification only, with the initial first step approach, we find that gamification or gaming, play could also refer to a very similar concept of gamification. Hence, these search terms were included in the search. And similarly, in mental health outcomes, other than that, treatment, prevention, illness, recovery were also other search terms that could be included in the search. So hence, with the initial MedNight and CNOW search, we found all the potential search terms and continue to use this all the search terms to search the databases, which later I'll touch on what the databases, followed by, after searching the databases and garnering a list of literature, the reference list of the literature and the different articles were also searched. So the database that was searched includes MedNight, CNOW, and PsycInfo. MedNight and CNOW to get more of the literature pertaining to clinical studies, as well as because this study aims to be specific to mental health outcomes, so we are not forgetting PsycInfo as a database to be searched as well. Indeed, you may say that this may be, there are only 3 databases, may not be very comprehensive, but because it's a preliminary studies as well as it's a scoping review, we start off from these more common databases to be searched, and Boolean operators were used as well. So the results that were shown were as follows. So initially we started off searching the databases to obtain more than 200 articles, but following the removal of duplicates and careful screening of all the articles obtained based on the inclusion and exclusion criteria based on the participants' context and concept components that we have searched, we finally obtained 8 articles, and these 8 articles were after rigorous screening were then included. And a little limitation of this is that methodological quality or risk of bias had not been reviewed prior to the decision to include the articles, but this is consistent with the guidance on conducting scoping review, because we wanted to be more inclusive. So hence we had not done the risk of bias assessment for each of the studies. But nevertheless, we ensured that the studies that were to be included actually met with the inclusion exclusion criteria set forth from the very beginning. So even despite this may be a little limitation, but the intent is to find out more about what are the gamification approach, with gamification in mental health being in its infancy. So for us, we find that this method suits the study intent. And because we wanted to find comparison groups, or we set off to find include only studies in comparison groups, so hence majority of the studies involve randomized controlled trials. And participants in those studies were aged 5 to 17 years old, mostly conducted in United Kingdom, United States, etc. And one of the key findings here of the gamification approaches were these 5 points here. Now, it was found that gamification approaches were best conducted using mobile devices, even though in those eight articles, there were also video games and computers may be used as well. And then some of it may be used in the presence of the therapist, some of it may be not. Particularly use of mobile device was most common and were used by individuals, children and adolescents at any point in time on their own time and own target, with or without the therapist's presence. So face-to-face gamification approaches involving therapy sometimes were used, but then it's not very common. But what may aside from use of mobile device being common, another commonality among all the 8 included studies were that all the gamification approaches involves the use of narratives. So there may be a scenario being painted, and then the player actually play a certain character in a storyline or a scenario. And not only that narratives, and as they progress in the game, they go through different levels within the game. So this is another key feature of the gamification approaches, other than narratives, that are leveling being used in the games as well. And the average duration of the games, or where the children and adolescents engage in the games, it was found to be at least an hour daily over 6 to 10 weeks in most of the 8 studies that were found. And some of the gamification approaches may also, other than the game, on the side there's a messaging platforms. So whereby even if there's no face-to-face gamification with the therapist, they may actually use messaging platforms to seek the help or chat with the therapist for professional help as well. So so with that, we also learned something that other than all these features stated here, the interaction may be also important, either face-to-face, which is not so common, but some form of messaging platforms. Now knowing that those are the few key features of gamification approaches to be used to help mental health in children and adolescents, we look at we want to expand, because earlier we do know that some of the preliminary evidence is only on depressive symptoms. So we look at different conditions as well. So whether gamification does have an impact on various mental health conditions. And for one of the conditions, attention deficit hyperactivity disorders, which is also a common condition occurring in children and adolescents. Yes, sorry about the running slides. It has been found that out of the review articles, gamification approaches could be potentially helpful for people with attention deficit disorders, because the studies, one of the studies had shown that people with attention deficit disorder had better organizational skills, management skills, being able to focus on their work, and also to focus on the organization of the things that they need to do in people with attention deficit hyperactivity disorder. And there's also another study showing that participants who had engaged in gamification approaches while having attention deficit hyperactivity disorders also garner better peer interaction skills, and in terms of their ratings by the therapist on the behavior after playing the games, there's also significant improvement. So with these 2 studies, out of the 8 studies, we find that gamification approaches could be potentially helpful, even though, of course, more studies could be done in future to provide more solid evidence. In terms of autism disorder, people with autism disorder, however, studies, and there was only one study of the 8 studies that examined specifically on effects of gamification in people with autism disorder, and there wasn't any significant differences found between those who engaged in gamification and those who did not. Then, plus also that in terms of the people with developmental coordination disorders, gamification was potentially helpful. There has been some improvement in motor proficiency, motor coordination, and their satisfaction if they would undertake gamification approaches. In terms of people with mood disorder, this is the part whereby there's greatest evidence, because among the 8 included studies, the most amount of evidence regarding gamification in children and adolescents were with people with anxiety disorders. Some studies have examined the mental health outcomes following gamification approaches, and consistently, it has been shown that gamification approaches could enhance the mental health of people with anxiety disorders, and more specifically in terms of relieving their anxiety and emotional symptoms. They consistently felt better when even compared to people who undergo cognitive behavioral therapy. Cognitive behavioral therapy is one of the so-called very commonly used therapies for people with mood disorders in adults, but also sometimes a lot of times in children as well. So, and in our reviewed studies, we found that consistently the mood and anxiety symptoms improved when gamification approaches was used, even when compared to those people who undergo cognitive behavioral therapy. So what may be a little limitation is that there has been most of these anxiety and emotional symptoms are self-reported improvement. So only one study had actually tried to review the biofeedback, whether the breathing rate breathing rate reduces lesser anxiety, biological symptoms, but not many have shown that. So there was only one study that shows this, and while a lot of times the improvement were in with regards to self-reported anxiety and emotional symptoms relief. So let me move on to the discussion. What we do know now is that most of the literature involving gamification involves users, children and adolescents with mental conditions using applications, video games, and then as we most of the time on mobile devices. And then also there were narratives in the game and leveling in the game. And these narratives and leveling seems to be very important, because another article by Fleming also the article by Fleming also suggests that when children and adolescents have access to games at their own time and own target, and then as they continue engaging in the game, playing the game, they build up a desire to level up or win the game. And in all this, it enables their focus to the intent or the treatment intent designed by the game developer, and hence minimize their distractions and being able to focus on the therapeutic intent. And typically in a lot of the games, as the players level up and progress in the game, they learn more and more tips and suggestions to manage their own mental health condition. So many of times the children and adolescents also feels empowered to take charge of their own mental health, and at the same time gather improvement as they learn more about strategies to manage their mental health. As we mentioned, there's only one study that utilized gamification approaches to detect biofeedback, breathing changes, etc., in terms of to judge the relief of mood anxiety symptoms. But nevertheless, future studies could also look into developing, with gamification, but other than looking at the self-reported outcomes or even therapist-rated outcomes, perhaps in building biofeedback into the gamification platform could be another suggestion to look at during the game development phase. Nevertheless, even if there's no limitations towards developing biofeedback into the game mechanism, but then messaging platforms is very common. It could be easily developed, and then it has been stated that when there's messaging platforms built into the game, so it is equivalent to the presence of the therapist, whereby there's also interaction between the person with mental health conditions, the player of the game, as well as the therapist. So in conclusion, what we already know about topic is that mental health conditions can be a global burden, can be part of the global burden of diseases in children and adolescents, as it's important to address them. And while games frequently associated with entertainment, education, it can be applied into traditional game-free contexts such as healthcare. And the potential for gamification in children and adolescents is huge, because I mean, most young people, as we mentioned, like fun, enjoyment, etc. So in children and adolescents, this may be the way that they learn best. So hence, it has a huge potential to be applied to achieve therapeutic outcomes in children and adolescents. And what we do know now, the key features allow the children and adolescents easy access through mobile devices to the game is most commonly used, if not at least computers, or and then with the use of narratives or storylines, and with the potential of leveling up mechanisms in the game. And what the evidence has suggested that there's a prominent impact of gamification, specifically in the relief of its anxiety and emotional symptoms. With some evidence suggesting it may be superior to traditional cognitive behavioral therapy. Now, think about gamification. If you have a if you have a therapist to be with the person with mental health conditions, it may take a few sessions, and it may take quite a long while. So therefore, if this learning can also take place at the individual's free time through the use of gamification, that could actually greatly reduce the therapist's time and effort to have face-to-face engagement with the person with mental health conditions. And while even when the person with mental health conditions is not engaging with the therapist, the person with mental health conditions is also learning about various strategies to manage mental conditions through the games, as they take on a certain character and then go along in the game, progress in the games with different storylines and different levels. The impact on biological responses of the gamification in mental health require further investigations. Similarly, the impact of gamification may be on certain disorders, may require further investigations as well. But the implications is huge, because health providers planning on implementing strategies can, other than using the different therapies that we already know of to help people with mental health conditions overcome their various signs and symptoms of mental health conditions, perhaps right now the evidence has suggested that has consistently suggested that it can help relieve mood and anxiety symptoms. So in addition to using the traditional therapies to help people with mood and anxiety symptoms, perhaps incorporating gamification approaches into the therapy may also be helpful. And further studies in future, people who develop games may also want to add on the biofeedback mechanism into the game to see whether it can achieve the same impact relief of mood anxiety symptoms with people with mood anxiety disorders. And even traditional therapies such as cognitive behavioral therapies and other psychological therapies could be presented in the gaming format. And given the potential evolution of technology, the potential for gamification for mental health outcomes remains very promising. And with that, I would also like to acknowledge the Nursing and the Institute of Mental Health for the methodological and content support in the conduct of this systematic review. Of course, not forgetting JBI, which comes up with the methodology to be used. And then actually, in all honesty, this was done as part of my project work when I was pursuing a specialist diploma in clinical trials program from Nanyang Polytechnic not too long ago. So with special thanks to the facilitators from this program to help in the methodological support for this study as well. So these are the references. And thank you very much for listening to me. And I hope all of us will have a think about how to use gamification approaches in our various work with our patients in order to enhance its therapeutic effects. Thank you very much. Have a good day.
Thank you, Dr. Xue, for that wonderful sharing. The second speaker for today's webinar is Senior Staff Nurse Adeline Kaur. Adeline specializes in geriatric care in the National University Hospital, NUH. She has experience in clinical practice and has led evidence-based research projects in the aforementioned field. May I invite Adeline to share about her project titled Nurse-Led Speech Therapist Referral Initiative in Older Adult Patients Using 4QT, a best practice implementation project. Adeline, please.
Slideshow. Okay, I can't see myself. Okay. Okay. Thank you, Azira. Yeah. Good afternoon, everyone. My name is Adeline, and I'm a staff nurse from NUH. And the project that I would like to share today is the project that I've done for my evidence-based clinical fellowship program. And the title is Nurse-Led Speech Therapist Referral Initiative in Older Adult Patients Using 4QT, a best practice implementation project. Okay, swallowing is a complex process involving a modulated neuromuscular reflex. It may be affected by many different disease processes, and it has been accepted as a geriatric syndrome. The prevalence of dysphagia in elderly is similar to patients with acute stroke, which has been reported to be as high as 50%. However, most health facilities do not routinely screen the elderly for dysphagia. Dysphagia is associated with increased risk of malnutrition, increased risk of readmissions for pneumonia, and increased length of stay and cost. Study from UK also showed that a delay in assessment or screening by a speech therapist is associated with increased mortality and morbidity. Recent studies have also suggested the feasibility of systematic screening protocols for identification of dysphagia among acute geriatric patients. And yeah. So in the past 8 years, there were 6 incidences of choking in elderly patients resulting in serious events in NUH. The current practice in NUH is where the doctor will assess whether the patient requires a speech therapist referral, and if the doctor thinks that the patient requires it, the doctor will refer in the system, and if the doctor thinks that the patient do not need any speech therapist referral, there will not be any intervention unless patient or patient's family member requested it, or when the staff nurses suggested it to the doctor. However, staff nurses are the ones who care for patients at patients' bedside most of the time. Therefore, there's a need to train nurses to perform dysphagia screening to identify early signs and empower nursing staff to refer patients to speech therapists for a more thorough assessment. A survey was conducted on 29 staff nurses working in the geriatric ward. From the survey, we can see that majority of the nurses have observed their patients choke or cough during or after a meal, highlighting the prevalence of dysphagia among patients in the ward. From question 2, we concluded that majority of the nurses assess patients' need for speech therapist referral during mealtime or when speaking to family. However, only 44.8% of nurses assess their patient for speech therapist referral upon admission. We have also collected data from 10 patients who required, we have also collected data from 10 patients who required a speech therapist referral and found out that only 70% of patients who required a speech therapist review were referred to the speech therapist within 1 day from admission or transfer. From the 10 patients who were referred and reviewed by a speech therapist, 60% of the patients required a texture-modified diet to reduce the risk of choking or aspiration. This showed that early speech therapist review is important. The aim of this project is to implement a nurse-led speech therapist referral initiative in older adult patients using 4QT screening tool. The first objective is to achieve 80% of compliance rate within 6 months on the use of this 4QT swallowing screening tool. And the second objective is to achieve 100% of patients who screen positive for dysphagia using the 4QT screening tool are referred to a speech therapist within 1 day. So the setting is in a general medical ward, and the inclusion criteria are patients who are above 65 years old, admitted or transferred to the ward, and being able to consume oral diet and being hospitalized for more than 48 hours. The exclusion criteria are patients who have been seen by a speech therapist before admission or transfer to the ward and have completed the dysphagia screening before admission, or are kept new by mouth and are on long-term NGT or PEG. So this project actually started in last year, June, where a team was assembled, followed by confirming clinical issues through survey and data collection, and also evidence review. After that is the implementation of practice change, where the teaching and application of 4QT takes place. And we then conducted a baseline audit, and the collected data were analyzed. And the analyzed data was then shared, and grid was conducted with the staff to gather feedbacks and suggestions to improve compliance rate. And collated strategies were then shared and reinforced to the staff nurses. And a follow-up audit was conducted and analyzed to assess the effectiveness of the strategies. And lastly, the upcoming plan for this project is that audits will be conducted every 6 monthly, and sustenance plans will be carried out. And this is the list of project team members. And this project is based on the best practice recommendations by JBI, where it suggested that as many neuromotor disorders are progressive, if dysphagia is suspected and not previously diagnosed, a referral for speech therapist is recommended. In another JBI evidence summary, it also suggested that validated tools should be used for nurse-initiated dysphagia screening. Nurse-initiated dysphagia screening should be performed by nurses who have received training on dysphagia. And lastly, patients who is screened positive for dysphagia should be referred to a speech therapist. The 4QT was developed following a literature review and in consultation with a team of speech therapists, geriatrician, and geriatric nurse. And this study has also shown that the 4QT has actually 100% sensitivity and 80.4% of specificity. And this is the 3-minute swallowing screening tool as shown in the slide, which consists of only 3 short questions, and nurses only need to answer the 3 questions accordingly, and the interventions for each questions are also listed in the table. And this screening tool is actually simple and does not require any intensive training. So a total of 7 sessions were conducted. 7 sessions of training were conducted for 2 weeks via Zoom by a senior geriatric nurse, and all staff nurses from the ward were trained to use the 4QT swallowing screening tool to screen all patients who met the inclusion criteria. And this is the audit tool that was used for audit. Okay, so the baseline audit results were shared with the staff nurses in the form of PowerPoint slides via official group chat, and staff nurses were then divided into subgroups, and each subgroups were actually led by 1 project team member to facilitate discussions for feedbacks, opinions, and also strategies to improve compliance. And from the group sessions, we actually identified 2 barriers, and this is the first barrier. So the first barriers identified is that nurses tend to forget to put up the swallowing screening tool template upon admission. So the strategies that we identified to solve this problem is to create a admission pack and to remind staff at every start of the shift, and also combine all the admission screening template into one in one note so that it will be more easily traceable. And the second barrier identified is that for cognitively impaired patients admitted during night shift, nurses were not able to screen them properly due to patients being asleep, and family members or previous institutions are not easily contactable during late hours. Therefore, the strategy to solve this problem is to include a reminder in the handover note so that the next shift nurses can help to follow up to complete the screening template. So this is the results. So based on the baseline audit and follow-up audit results, we concluded that there was an increase in compliance rate of nurses using the Solwing screening tool from 64% to 71%. However, there was a decrease in compliance rate on patients who screened positive for dysphagia were referred to the speech therapies from 92% to 86%. And one of the possible explanation for this decrease in compliance rate could be due to the institution-wide change in healthcare software occurred between the baseline audit and follow-up audit. Yeah. So, okay. We have also collected data on the number of days from admission or transfer to speech therapist referral. So out of the patients who required speech therapist referral, all patients from the baseline audit and follow-up audit were referred within 1 day, as compared to pre-implementation where it is only 70% were referred within 1 day. Yeah. So the implementation of the Solwing tool has enabled early referral to speech therapists and reduced risk of choking within the ward. In conclusion, we did not achieve our objectives as we only achieved 71% of compliance rate as compared to 80%, and also 86% of compliance rate on speech therapist referral instead of 100%. However, the best practice has empowered our ward nurses to identify the risk for dysphagia in elderly patients. And this project will continue with another GRIP sessions and a sustenance audit will be conducted to ensure our objectives are achieved. I would like to thank the above colleagues for rendering their support in this project. And this is the list of the references. And thank you everyone for your time. I will now hand over the session back to Azira. Thank you.
Let us welcome Senior Staff Nurse Nicholas Neo for the third presentation today. Nicholas is a registered nurse at the National University Heart Centre, Singapore. As a JBI Clinical Fellow, he is actively involved in evidence implementation within cardiovascular nursing. May I invite Nicholas to share his lessons and perspectives on implementing best practice in an acute care setting. Nicholas, please.
Okay, thanks Azira for the kind introduction. So just let me share my screen. Okay, and we are good to go. So good afternoon, everyone. My name is Nicholas, and I'm a registered nurse from the National University Heart Centre, Singapore. Thank you for attending my session where I'll be sharing some lessons and perspectives related to the facilitation of evidence-based practice. So the session will be quite anecdotal. So hope you enjoy the stories I'll be sharing. So this will be the content of today's sharing. My institution, the National University Hospital, adopts the JBI Evidence Implementation Framework for the dissemination of best practices within our clinical areas. I will share an overview later from members of the audience who are not very familiar with this framework. I will then take you through some of my department's achievements following implementation activities. However, the bulk of my presentation will relate to how our nurses engage project stakeholders and contextualize our best practice recommendations. So before I begin, I would like to share a little about myself. I'm from the National University Heart Centre, Singapore, or NUHCS in short. My department consists of patients admitted under the cardiology, cardiothoracic surgery, and vascular surgery specialties. We are a national heart centre that strives for clinical and research excellence. And I'm based in one of the 3 general wards within NUHCS. As you can see, these are some of my friends in my clinical area. So My area of specialty is cardiovascular nursing. I also lead the Cardiovascular Evidence-Based Nurses Collective, a nursing EBP work group that specializes in improving nursing practice and standards using the latest evidence. I've also completed a JBI Evidence Implementation Training Program in 2019 and have since assisted with evidence-based nursing activities in my department as a JBI Clinical Fellow. So moving on to the presentation proper, I would like to share about the recently updated JBI Evidence Implementation Framework. It's something I find particularly useful for clinicians who are not familiar with evidence implementation. So it consists of 7 phases related to context analysis, facilitation, and evaluation. So I'll briefly walk you through each of the phases. So starting from phase 1 of the implementation cycle is where an initial meeting happens to identify the clinical issue. So all potential stakeholders should be involved and agree that an issue is meaningful to explore. Following that, in phase 2, change agents or people that are interested and appropriate to champion the related change should be identified and a team should be formed. Phase 3 involves the assessment of the macro-clinical environment. This involves the review of existing workflows, manpower, and infrastructure. Phase 4 is a review of current practices against evidence-based criteria. So JBI actually provides some evidence summaries and best practice recommendation sheets to support this. So for clinicians who, without this access, you should search for high-quality literature like systematic reviews of randomized controlled trials, or conduct critical appraisals of primary studies before implementing the associated interventions. Phase 5 is the implementation phase, where the intervention is introduced to the clinical setting. Prior to this, clinicians are encouraged to identify the change barriers and generate strategies to overcome them. GRIP, or GRIP, or Getting Research into Practice, is a JBI tool that guides clinicians with this process. Phase 6 is the evaluation phase, where we evaluate compliance to the new practice and quantify the outcomes of our project. We can then reassess our intervention to address issues that surface. Phase 7, which is the last phase, will be the consideration of how the intervention can be sustained. So common strategies include periodic audits and assimilation into the institution's protocols and processes. So more information can be found on the JBI webpage. The JBI Evidence Implementation Training Program is also a good resource if you wish to learn more about this framework. So my department has utilized this framework with great success. I'll now share some of the results of our evidence implementation efforts. For practice updates, NUHCS implemented 2 projects with stellar results. The enhancement of subcutaneous anticoagulant injection techniques allowed our patients to experience less bruising and pain following blood thinning injections. And the reinforcement of best practices in IV cannula care and an institution of a push-pause positive pressure flushing technique also reduced rates of phlebitis. For nurse-led interventions, our nurses took the lead to improve patient outcomes. The nurse-led lower limb exercise that was added to our hospital's fall prevention processes helped reduce fall rates. This was implemented in NUHCS to improve patient safety. The nurse-led medical rounds promoted nursing leadership and patient advocacy, encouraging our nurses to highlight clinical and discharge issues timely. Ultimately, this helped to reduce our patients' length of hospitalization. Okay, so the last project I'll be sharing will be with regards to supporting and engaging our patient as an important resource. So this was evident by the patient-led intake output charting initiative, which promoted fluid management, an important lifestyle modification that extends beyond the inpatient setting. This is, however, one of the projects that we feel that have some room for improvement. So it's a work in progress for our department. So I'd just like to take the opportunity to appreciate all my nursing colleagues in NUHCS for their contributions to greater patient outcomes and supporting a culture of evidence-based practice. I would also like to thank the NUH Evidence-Based Nursing Unit for their mentorship and guidance for our EBP endeavors. So however, evidence implementation is not always a smooth sailing. This because it involves busy clinicians who are already preoccupied with their existing work. So today, I would like to share some of my experiences from past EBP projects. I'll be talking about common barriers and how some of the projects overcame them. There were also some interesting change facilitators that I believe will be useful for clinicians interested in EBP. So there are 3 common barriers and 1 facilitator that are recurring themes within my department. I will also give some examples of how the project teams address them to their advantage. So the first barrier actually relates to something that I think most of the clinicians resonate with. So it's regarding the resource of time. So nurses are frequently concerned about the amount of time required to implement a new initiative. As much as we want to improve our patient's outcome, we must acknowledge that we are actually busy clinicians ourselves. So it's always important to ask how the new implementation interacts with the clinician's existing workload. To improve synergy, the project intervention should align with the clinician's workflow. So in the nurse-led medical round project that I've shared earlier, the nurses and doctors had to come to a consensus about the rounding timing to facilitate this collaborative effort. There were also many rounds of discussion to manage to optimize the rounding checklist, which is a list of items that the nurses would be presenting to the multidisciplinary team to optimize the nurses' workload. So change strategies based on feedback increases the odds of project success and sustenance. So it is also important to consider the patient's characteristics on top of the proposed intervention. So for the lower limb exercise project shared earlier as well, 2 simple exercises were implemented. However, despite the intervention's simplicity, the nurses found it time-consuming to conduct one-to-one teaching for elderly patients who require repeated explanation and correction. So this led the nurses to think about alternate ways of providing this piece of education. Okay, moving on. So the next point relates to team communication, which is something very, very important. And I'll be sharing some pointers related to engagement with nurses, patients, and the multidisciplinary team. So the main stakeholder within our projects are actually nurses. So as such, it's important to listen to what they have to say about the clinical problem. It's crucial that they agree that there is an issue and that the proposed intervention is workable. One tip would be starting feedback sessions by recruiting general comments instead of the team's conceived intervention. So this creates an engaging and open environment for the nurses to share their thoughts instead of feeling that an intervention is forced onto them. Following that, the project team may employ strategies to address the concerns that the nurses may have. Okay, so in our department, we also have patient-led initiatives. So as such, patient engagement is also an important aspect prior to implementation. So these are some questions that I would like the audience or any project team leaders to ask themselves and their patients. So do they find it meaningful? Do the patients find meaning in being more participate more in their care? So is the intervention easy to follow? So do our selected patient profile able to follow a set of intervention or exercise that the implementation requires? Or what can help them perform this proposed intervention? This include learning aids, PFEs, and maybe even videos or using technology to supplement your intervention. So projects that fail to recruit patient opinions tend to experience disengaged learners, which is something we don't want to have. And this also means that the intervention is actually insufficiently tailored and contextualized. So our patient engagement initiatives like the lower limb exercise program refine their inclusion and exclusion criteria to overcome this. There was an interesting inclusion criteria called willingness to learn. So this helped nurses focus their efforts and add value to patients who are willing to engage. For multidisciplinary team projects, the various healthcare teams should also be engaged at all junctures. This helps to align priorities and resolve potential issues during the implementation phase. An example would be the nurse-led medical rounds, where the nurses highlighted behaviors that affected their confidence and ability to present their cases. This included interruptions and a tendency for some physician teams to be impatient and rushed. On the other hand, the medical team would like to know how they could include and effectively engage nurses in their teaching during the morning rounds. This feedback led to midpoint reviews and engagement sessions to address issues raised. Moving on, the third barrier is actually concurrent project activities in the clinical setting. So nurses had issues coping when the timelines of new implementations and prior projects overlap. As such, there is a need for good communication between the project team to facilitate the creation of a departmental work plan to deconflict EBP activities. So priorities may be set during meetings between team leaders. Okay, so the last team that I'll be sharing, is actually a facilitator. that was uncovered during our feedback sessions and discussions. So nurses actually exhibited a spirit of self-improvement and continuous learning when it came to nursing practice updates derived from new evidence. So hospitals are a congregation of nurses from different backgrounds and practices. This results in certain nuanced differences in the provision of care. So most nurses are actually quite receptive when you highlight the rationale and positive results of change. So this worked especially well for simple practice change. So an example in my department would be the project involving subcutaneous injection techniques. So nurses were required to administer the injections over 10 seconds, keep the needle in for 10 seconds before needle withdrawal, and institute a 10-second compression over the injection site with an alcohol pad. So nurses were generally happy to comply after we highlighted the rationale for each action and shared the positive effects the project had on their patient, which is a very significant amount of reduction in the bruises that we see, and it's something very visible and from their day-to-day interactions with their patient. Okay, so I would just like to summarize everything that I've shared. So what I want to bring across today, right, is firstly, communication is key for successful evidence implementation, and this must involve all stakeholders, including patients and the multidisciplinary team. We have been able to identify interesting viewpoints that added value to our projects from these interactions. I also hope that EPP practitioners adopt an open and flexible mindset as they engage their stakeholders. Show your stakeholders that you are listening and committed to addressing their concerns. However, leadership is also important in evidence implementation, and there is a need to be assertive when you champion change, especially after strategies are adequately put in place to support them. Lastly, I would like to acknowledge that evidence implementation is not entirely effortless. This is especially true for new nurses. My advice for novice nurses is to press on and learn as much as you can from your initial encounters with EBP. So every implementation cycle is an opportunity to learn, and I guarantee that the process gets easier as you move along. So for seasoned facilitators of EBP projects, I hope you continue to mentor your newer team members. So remember that they will only truly see the importance of evidence-based practice if they enjoyed and had a good experience. Okay, so I'd like to end my session with a quote my mentor has always shared. So it will never be a perfect time. You can only make time perfect. I think this sentence embodies the spirit of nursing evidence-based practice and quality improvement. There's never enough time and resources to go around, but we can make the situation more ideal by actively listening and incorporating tailored strategies. So with that, I end my presentation. So you may direct questions to me during the upcoming Q&A session. Alternatively, these are my contact details. So do follow the Instagram page of the Cardiovascular Evidence-Based Nurses Collective via the handle at CNC_EBP or the QR code provided. We are a new initiative, so do give us your support, especially if you are interested in evidence-based practice or cardiovascular nursing. Yep. So that's the end of my presentation. I'll hand the time back to Azira. So Azira, please.
Thank you, Nicholas, for that wonderful sharing. I would like to thank all three speakers once again for the informative and thought-provoking presentations. I hope everyone has enjoyed the presentations as much as I did. We will now be proceeding with the Q&A session with our speakers. Participants can still continue to submit any questions you may have related to the presentations or regarding evidence implementation in general. You may submit your questions to us through Pigeonhole by scanning the QR code or typing in the URL shown on the screen and entering the passcode. Participants can also vote for the question they would most like to be answered. However, due to time constraints, we will only be able to address a limited number of questions. Okay, so for the first question, we have, does NUH or IMH conduct training on using the JBI framework? Perhaps I can invite Dr. Siti to answer this question.
Okay, thanks, Azira. Okay, for NUH, yes, we do conduct the JBI comprehensive systematic review as well as the evidence implementation. Yeah, so these are the two JBI courses that we actually run at NUH. Yeah, so if you're interested, maybe you can write in to us, then we can explore how we can actually offer the courses.
Okay, how about Dr. Hui Ting? Would you like to share regarding IMH side?
Hello, thanks for the question. So at Institute of Mental Health, just as in all courses that we conduct, we do customized courses based on the needs of requesters. So as long as the requester have a certain is able to form a class and they would like to request certain training, we are able to customize courses for them, including that of JBI, Comprehensive Systematic Review, which we do have trained trainers. And otherwise, other talks about JBI methodology and framework in general, we are able to do that based on request basis as well. Thank you.
Okay, thank you, Dr. Siti and Dr. Xue. So the second question is, based on the key features of gamification approaches, such as the use of mobile devices, narratives found in this review, what could be the potential implications? I'd like to direct this question to Dr. Hui Ting.
Hi, thank you for the question again. So just now, I think we will share a few key features such as the use of narrative storyline, and then having the games being easily accessible on mobile devices, etc. So and some of the implications, as we mentioned earlier, perhaps it can be complementary to current existing therapy, and one of the therapy being cognitive behavioral therapy, whereby perhaps in any cognitive behavioral therapy session, the participant or the person in mental health conditions may have to think through the pros and cons of their mental health conditions and the actions and the behaviors that they are taking. So perhaps one of the implications can be in the essence of therapies, a game which encompass similar features as this could be built in. Maybe there could be a narrative of the mental health condition being something, a monster or some character, and then the person with the mental health condition can also play a human character or any character inside a game with a narrative storyline. And then this person, this character or player perhaps are faced with certain anxiety or provoking situations, and this would have to choose certain ways to react. And based on the back end, the algorithm could be built in such that based on the ways that they react, they could get, if they choose the more appropriate behaviors or actions, and then in the game, the scenario may play out in a more positive way, whereas if they choose something behavior that is not so productive or not so encouraged, then the scenario plays out in a more negative way. And the potential to, as the scenario plays out in a more positive way, the potential to level up or progress in the games increases. So this could keep the player motivated in being in the game. At the same time, they could also learn strategies to manage their anxiety-provoking situations through this game. So that could be one of the implications that could be done. Thank you.
All right, thank you, Dr. Xue. I'd just like to move on to the third question that we have. Do you think the dysphagia screening is feasible and has value at the outpatient setting? I'd like to direct this to Adeline, please.
Okay, so from my opinion, I think that this dysphagia screening tool will definitely be useful in outpatient setting, especially if the patient's profile consists of mainly elderly patients or patients who are at high risk of aspiration, as this will help to identify risk of aspiration or choking early. And while for the feasibility, I think that it is definitely feasible, as this screening tool is actually quite short and easy to use, which is it will not take out a lot of the nurse's time. However, it will be good to consult all the stakeholders before implementation.
Right, I think we have time for one more question. Maybe I'd like to ask Nicholas this question. What are the tips to sustain EBP or quality improvement projects?
Thanks for the question. Actually, most of my presentation pertains to how we can more successfully roll out EBP projects or QI quality improvement projects. So the same 4 themes actually applies for the sustenance phase of our projects as well. So if you look back at the JBI's framework for evidence implementation, so phase 1 to 4 is actually more of a planning phase. So 5, 6, and 7 is actually the implementation and the evaluation phase. So once you run a project, and you reach the implementation phase, you will go on to the evaluation to see what are the barriers and difficulties your stakeholders have. And then from there, you can tweak your implementation strategies and re-implement it again to the ground. So I would say this is using the JBI implementation strategy is a good way of like looking at sustenance. So something that appeared in a very interesting like point that appeared in my department would be the participants that we engaged. So I found that actually when we are pushing our projects into the wards, right, the newer nurses are actually a source of enthusiasm for our projects. So you can, I noticed that the new nurses who are joining our departments actually champion our projects and actually implement them more consistently and also with more enthusiasm when they learn about evidence update or updates to their nursing practice. So I guess other departments or other stakeholders or other institutes who wish to like do EBP or quality improvement can look into that as well. Then overall, I would say have a good idea of the EBP and quality improvement initiatives within your department so that you can monitor and track the progress and also see when you need to divert more attention and also relook at the initiatives to improve them. Yeah, so I guess these 2 points. So maybe looking at younger nurses or younger stakeholders and also having a good overview and after discussions with your stakeholders. Yeah.
Thank you, Nicholas. All right, since there are no more questions, I'd like to close the event. We have now come to the end of today's JBI Global Solution Room. I would like to extend our appreciation to all the speakers and attendees. I would also like to thank JBI Adelaide, the National University Hospital, and the Institute of Mental Health for their support in this event. We hope you have enjoyed this webinar. Once again, thank you and have a nice weekend, everyone.